Hello, everyone. My name is Ramzi Ajlan, and I would like to thank the organizers for inviting me to speak. I mean, obviously, I would have loved to be with you, but unfortunately, given the circumstances, I can't be there, and we will do this online. So, I'm tasked by talking to you about the management of thyroid eye disease, or also called thyroid-associated ophthalmopathy or Graves' orbitopathy. What I'm going to try to do is to tell you the latest in the field, but I will focus mainly about our practice, what we do in our multidisciplinary clinic in Leeds, UK. So I'm going to make it as practical as possible. This is my disclosure slide, and moving on from there. Now, let's start with some facts and natural history. Now, around 40% of individuals with Graves' disease actually display clinical thyroid eye disease, but the symptoms and signs are frequently missed. And if you do an MRI in people with Graves' disease, almost 4 out of 5 will have changes consistent with thyroid eye disease, but the symptoms will be very, very mild in these guys. Now, in the majority of cases, it is a mild and self-limiting condition. Almost 80% will have that. You've got around moderate to severe in a fifth and life-threatening in a minority. But life-threatening is really an issue, and we have to be very careful about it. Now, one thing about thyroid eye disease is suboptimal management is common. And part of the problem is that we do not pick up the condition in a timely manner. And you've got to, I always tell my patient that, look, this is a self-limiting condition, but what we need to do is this. So if you look at the natural history of the condition, the dotted red line is the active disease, and then the solid line is sort of the severity, what it leaves you with in a sense. So we want to control that red phase when the disease is active. So if we can suppress that phase, then the severity of the disease will be less. So that's why I like to pick it up very early on and initiate early treatment. So locally in our center, I also ask my colleagues that if you have sort of a condition, you're not sure how severe it is, please refer, and we see the patients at the drop of a hat. We see them very, very quickly. Now, what are the factors that are increasing the risk of thyroid eye disease? Now, diabetes is one of them, and the risk may be modulated by higher glucose levels. So higher A1C usually associated with worse thyroid eye disease. So we need to control glucose levels, but please do not use a glitazone, because glitazones have been known to be associated with increased thyroid eye disease risk and severity, as you can see in that and the picture on the right. This is somebody who was given a glitazone and thyroid eye disease developed and got worse. The other thing is high cholesterol. Statins are useful here. And remember, statins are anti-inflammatory, which can be helpful in this condition. Smoking. It's an absolute must to stop smoking in people with thyroid eye disease, and we strongly advise them to do that. The other thing that is not advised is fluctuating thyroid function, particularly people going underactive. If the TSH levels go up, then you can get more severe thyroid eye disease. So we like to maintain euthyroidism, and we use block and replace in our clinic to avoid this fluctuation. High dose carbimazole with thyroxine on top. Now, when it comes to radioactive iodine treatment, it is best avoided in people with active eye disease. And this is why I'm always very keen to look for thyroid eye disease before giving a radioactive iodine treatment for people with Graves' disease, because it can certainly exacerbate the condition. If you absolutely have to, you need to cover with steroids. And of course, in males, the condition tends to be more severe, but we can't do much about it other than pretty aggressive treatment. Now, when it comes to assessment, we actually use a really old score, which we haven't changed. There are some other scores that people use, but this is what we use here, that we haven't changed this for years, actually. We look at the clinical activity score. And to keep it very simple, I go for pain, so pain on eye movement or pain at rest, redness of the eyelids, redness of the conjunctiva, swelling, swelling of the eyelids, conjunctiva, and then you've got that caruncle, the swelling of the caruncle. And if the swelling of the conjunctiva is severe, that edema is severe, it is called chemosis. You see it once, you never forget it. It's pretty nasty. Of course, then you have the disease severity. So we've got mild or moderate to severe, and this is all related to eyelid retraction, exophthalmos. So if you have more than 3 millimeter of exophthalmos, it's moderate to severe. Soft tissue involvement, you see the inflammation. Again, that can distinguish between mild and moderate to severe. Extraocular muscle involvement. So if you have sort of intermittent diplopia, that's less of a problem compared with constant diplopia, for instance. And of course, corneal involvement, something you've got to take very seriously because that can be sight-threatening. So if people cannot close the eyelids and the cornea is exposed, you can get corneal involvement, and that's pretty significant, and you have to take it serious. So when it comes to clinical manifestations of Graves' ophthalmopathy, these are some of my patients who kindly agreed for the photos to be taken. So you've got the person on the left, the lady, she had a clinical activity score of 7 out of 7. She had everything. She had the pain, she had the redness, she had the swelling, she had absolutely everything. On the right, you see somebody with chemosis with this conjunctival edema that I told you about, pretty severe, and it's unilateral here. Now, in the second row on the left, you see somebody with different manifestations. So you've got a bit of proptosis in the right eye. You've got swelling and edema of the eyelids, swelling and redness of the eyelid on the left. The person on the right, in the middle row, what you can see here is somebody's trying to look up, and the right eye goes up, but not the left, and of course will have diplopia. Now, some people, if you look at them, so face to face, you will not see major differences, but if you start looking from the top of the head or the bottom, then you can see actually pretty significant exophthalmos. I must stress that a multidisciplinary clinic here is very helpful, and this is what we do in Leeds. So you have an ophthalmologist, you have also an optometrist, so you've got a proper team looking after the patient plus the endocrinologist, and that's myself. So everybody will do their own job. Now, just to again demonstrate to you sort of the difference between sort of mild, moderate to severe, and sight-threatening. On top, you've got somebody with mild thyroid eye disease, and typically that will have minor effects on daily life activities. The lid retraction is minor, the proptosis is less than 3 millimeter, and the soft tissue involvement is quite minor. And then they can have intermittent or no diplopia at all, no corneal exposure. Whereas in moderate to severe, it can affect daily life activities. The proptosis will be more significant. The lid retraction is more significant. And then they can have diplopia. And you can see the person in the bottom, somebody's got constant diplopia. The one on the right is very similar to my lady, having pretty severe soft tissue involvement, as you can see. And then in the bottom, you've got somebody on the right who's got that corneal breakdown. You've got to really be very careful about that. And on the left, you've got this apical crowding, and that can affect the optic nerve. So we always examine the visual fields. And I ask a very simple question about color vision. Is the color vision affected? Because, the earliest sign of optic nerve involvement is loss of color vision. So it's something that we ask about and we test for as well. So of course, you need to consider other diagnoses and you need to investigate accordingly. A very common one is allergic conjunctivitis. You get a little bit of redness in the eyes, but sometimes, not infrequently, people are misdiagnosed as allergic conjunctivitis when actually they have thyroid eye disease. Myasthenia gravis, remember, it can be associated with thyroid eye disease. The history is suggestive. Usually, they get more diplopia at the end of the day, more than the beginning of the day, and you can do some testing, including antibody testing. Orbital tumors, pseudotumors, we've seen that, but it's relatively rare, luckily. Carotid cavernous fistula, you see it once, you'll never forget it because the eyes will be pulsating. We had a couple of patients. Their orbital myositis is pretty nasty, and you can tell that that's different. It's usually unilateral as well. You need to do an MRI. We don't do MRIs in everybody routinely, but we do it in unilateral disease. We do it in suspected Graves' ophthalmopathy, but normal TFTs and negative antibodies. That's a small, very small proportion of patients have that, but they can still have Graves' ophthalmopathy. Divergent strabismus, you've got to do it. Diplopia sole manifestation, and any atypical case. Whenever we feel uncomfortable, there's something not right, you do an MRI. And we also do an MRI if they're not responding to the treatment as we feel they should. So atypical cases, please go ahead and do an MRI. Now, when to refer? And we developed sort of referral criteria for our center, but you may want to adopt it to your local arrangement. So what we do, what I told my colleagues, I want to see an urgent referral if they have a decrease in visual acuity, they've got impaired color vision, or sudden onset proptosis. And if they have the signs of corneal opacity, again, I'm talking about this again and again because it is important. Lids fail to fully close, abnormal discs, and visual field defects. I want to see an urgent referral. Routine referrals, they've got this gritty sensation in the eyes, which is very common, a bit of pain, double vision, progressive proptosis. Routine referral is fine. And if they have the signs of redness, swelling, eyelid redness, swelling, restriction of eye movements, and proptosis, unless it's sudden, again, routine referral is fine. But what I always tell my colleagues that if you're not sure, just refer. Don't play with it. We see them very quickly, and then we can reassure you and the patient. Now, always, you need to ask the individuals to stop smoking and maintain euthyroidism, and we use block and replace for that in our center. Now, when it comes to the management, so if you look at it a decade ago, as you can see, for mild disease, it was sort of local measures, artificial tears, etc. And then moderate to severe, you would go for IV glucocorticoids. We very rarely use oral. It's IV glucocorticoids that you want to use because we know they work better. And if you have sight-threatening disease, you go for a short period of IV glucocorticoids, no response within 2 weeks, then you go for decompression surgery. So this was 10 years ago, but things have changed a little bit since because of these two agents. So what we've got IL-6 and IGF-1 directed therapies, right? So the IL-6 antagonist of tocilizumab, it shows that actually it can change the progression of thyroid eye disease. So it's something that can be used. And the one that is even more interesting is anti-IGF-1 receptor therapy, teprotumumab, because this is one treatment that affects proptosis. Everything else doesn't affect proptosis. This does, even in the chronic stage. So it's very, very exciting. At the moment, in Leeds, we're using it in research more than clinical because we haven't got the funding. It's a very expensive treatment. And as you know, the system in the UK is free. So we haven't got approval yet to start it in everybody with thyroid eye disease, but we're using it, we're enrolling people in research study and using it that way. So the more recent guidance from 2025 evolved, and it goes like this. If you have mild disease, you can wait and see and put them on selenium. Selenium, particularly in places where there's selenium deficiency, can be quite helpful. It's an anti-inflammatory. Side effect profile is brilliant. So you can't do any harm. Put them on selenium. It's cheap, well tolerated for at least, for what we go for 6 months. Now, if you have moderate to severe, then you look at the dominant sign. Is it proptosis or is it inflammation? Proptosis or diplopia dominant, you go for an IGF-1 receptor blockade if available. If not, you go for interleukin-6 receptor blocker. If that is not available, you go for glucocorticoid with radiotherapy. Now, we do radiotherapy if we feel they're not responding well to IV glucocorticoids. But if you're responding well, we wait with radiotherapy usually. Now, if you fail, you go for second line, which I'll talk about in a moment. If inflammation is dominant, you go for IV glucocorticoids or IL-6 receptor blockade. If you have that, we use IV glucocorticoid. When you have site-threatening, then again, it's more or less these three agents that you go for. If you have availability of IGF-1 receptor blockade or IL-6 receptor, you go with those. If not, IV glucocorticoid. And I must say the IV glucocorticoids are not bad at all. They work in 90% of patients, and our experience with them has been very good. There are different regimes to use. We use a very simple regime of 500 milligram every week for 6 weeks and 250 every week for 6 weeks. So the whole course is 12 weeks. But you can use other regimes if you're really forced to. You fail, you need to reassess within 2 weeks max. If you fail with that, you go for decompression surgery. Now, you may say, what is the mycophenolate? Because you say use mycophenolate with the glucocorticoids. The evidence, there's some evidence for and against. We do use mycophenolate for very severe disease in combination with glucocorticoid, but we do not use it routinely in everybody. So it's very much assessment, multidisciplinary team discussion, and then we decide whether to add in mycophenolate or not. Now, what about second line therapy? So you've got rituximab, as you know, it's an anti-B cell therapy. The evidence is somewhat conflicting if you look at the various studies. We have used it in half a dozen of patients, and our experience has been positive. These are people who did not respond well to glucocorticoid, but the numbers are relatively small, so I can't tell you more than that. Cyclosporine, we use actually quite a bit. It works particularly if we need to use steroids for a longer period of time. We combine it with steroids and then we withdraw the steroid. And it seems to work, at least for us. You've got to be very careful about blood pressure. You need to monitor it. You need to monitor UNEs very carefully after starting treatment and as you escalate the dose. And of course, lipids as well. Sirolimus, some small studies have shown benefit of this agent. It is promising, but I think more work is needed. We don't have much experience in using this, other than a couple of patients actually who needed it for other reasons anyway. They've got rare therapies like azathioprine, even methotrexate, very limited efficacy and not widely used, so we do not routinely use them. We use azathioprine on somebody with thyroid eye disease plus Crohn's, and it actually did work after a period of glucocorticoid treatment. But again, numbers are minuscule to give you any meaningful feedback. So what about surgery? Now, the surgery you needed for site-threatening active disease if glucocorticoids or other therapies did not work. And we had to do that on a few occasions. We do it a lot less now compared with previously because we are catching the patients very early on. Corrective surgery, once the active phase is over, we do a lot of lid surgery, squint surgery, and also proptosis for cosmetic reasons, and also to improve the squint. And our results are quite good. And you can see some absolutely dramatic improvement after surgery. This is your before and after, and again, before and after surgery. So to summarize, ladies and gentlemen, proper assessment of thyroid eye disease is important, but not always done. Early referral to specialized clinic is encouraged, and a clinic in Leeds has been running for almost 2 decades now. It is very important to maintain euthyroidism. It is important to stop smoking. I mean, particularly, you want to avoid over-treating grave disease and putting the patient into a hypothyroid status. That definitely will almost guarantee that the eye disease gets worse. Simple measures can be used by the non-specialists in terms of artificial tears and selenium. And then when it comes to more significant disease, IV steroids remain the main agents used in the medical treatment unless you have access to these newer agents. So in terms of mycophenolate, you use it with glucocorticoids, it's advocated by the UGOGO guidelines. Then you have the anti-IGF-1 teprotumumab. It's the only agent to reduce proptosis, even in chronic cases. It's got some side effects you've got to be careful about. before you start it, and it's very, very expensive. You've got the anti-IL-6, the cyclosporine we discussed, and the rituximab as well. In terms of other than medical treatment, there is radiotherapy and surgery. So the radiotherapy, you can combine it with the glucocorticoid treatment. We use it if the glucocorticoid treatment did not have the desired effect, and it actually works very well. But when you go for radiotherapy, just make sure they are on steroids, because radiotherapy works much better if the patient is on steroids. There are some other treatments in the pipeline, but I don't have much time to discuss that. And therefore, I'm going to stop here and would like to thank you very much for your attention, and hope all the conflicts in the region clear soon. And please stay safe. Thank you again.